seem to be the eternal chairperson for the afternoon, so I will ask my colleague, Dr. Janaka, to introduce the next speaker.
Good evening. Our next speaker is Dr. Rohan Gunawardana. He is the consultant cardiac electrophysiologist at the National Hospital. He will be speaking on useful insight into the arrhythmias and overview. Over to you, Rohan.
Thank you, Janaka, for that introduction. Maybe not the best time, the late evening might not be the best time to talk about arrhythmias, and I'll try to keep the few of you awake if I can. Right. Now, let me first say that when a clinician, whether it's a physician or even a cardiologist, or even sometimes even us, when we come across the arrhythmia ECG, sometimes we just step back and think, oh, what is this? This looks horrible, I can't analyze this. But if you really look at it, if you go by first principles, go back to your early learning as a medical student, as a junior doctor, I'm sure you will be able to analyze most arrhythmia ECGs adequately to be able to come to a conclusion, make a diagnosis, plan the initial management and the future management as well. And I hope I can prove to you that this can be done by anyone in the next half an hour or so. This is a case-based discussion, interactive, I hope. If I ask questions, I hope somebody may be brave enough to raise their hands. Can I just get this going? Yes. Right, so the first patient is actually a 75-year-old man who presented to the NHSL about nearly a month ago, and he has come with episode of syncope. He had several such episodes before that. The first episode, he didn't think much about it. He didn't go and see anyone. Second episode, he had gone and seen a GP who had said, oh, there's nothing wrong with you. Everything is fine, done some investigations. And this is third episode. He just dropped. There was no warning, and there was no relationship to any posture or anything like that. And otherwise, he was a very fit man. He said, oh, this is the first time I'm being in hospital, in fact. Right? And he was then admitted to the medical ward, and where a 2D echocardiogram was done, and which was found to be quite normal. Now, this was the ECG that he presented with. This is not his actual ECG. I'm showing a very similar ECG merely for clarity. Now, let's see how we analyze this. Analyze this ECG. So, going by first principles, the first thing we do when you see an ECG is look at the rate, and that's very simple enough, right? Pardon me if I'm going to be very, very basic sometimes, but I think it's always good to go back to our basics and learn from that. So, simple enough, we divide 300 by the number of large squares between two RR intervals, and here we have about just a little bit more than 3 large squares, which means that the heart rate is just below 100, so maybe about 90 beats per minute, which is essentially normal. Right? Now, the next thing that we want to do when you see an ECG is decide whether this is a sinus rhythm or not. And to do that, you need to first see, is this P wave created by a sinus impulse or sinus beat, a sinus beat, right? The best leads that we know, again, from our teaching to assess the P wave is lead 2. But here, of course, in lead 2 is slightly hidden, the P wave, but still you can see there's a positive P wave. Another useful lead is V1, where you see a bidirectional P wave. You can see the bidirectional P wave. So we assume that this is a sinus rhythm. At least this P wave is created by a sinus beat. Now the question, when you say sinus rhythm, what we are saying is that the ventricular activation is by a sinus beat. And to do that, you have two criteria. That is, every P wave must be followed by a QRS complex, and every QRS complex must be preceded by a P wave. And here, if you look at this rhythm strip, you see that that is clearly there, though there is some problem here. Every P wave is followed by a QRS complex, and every QRS complex is preceded by a P wave. So this is sinus rhythm. Right. The next thing that we want to see is the PR interval, and here we see obviously there's something wrong, because we know that the normal PR interval, which is 200 milliseconds, roughly, or below 200 milliseconds, or one large square, has been exceeded here, and you can see that here the PR interval from the beginning of the P wave to the beginning of the QRS complex is is about 1.5 large squares. So there is a prolongation of the PR interval. That's the first abnormality we have detected on this ECG. Right. Next, we look at the QRS complex. Now we know that the QRS complex is generally narrow. It is around 100 milliseconds or 2.5 small squares. Right. And here we can clearly see again that this QRS complex is quite broad, being about 3 small squares, and therefore there is a broadening of the QRS complex. Now we know that if it is a sinus rhythm and there is broad QRS, this is indicates that there is a conduction block, or there is difficulty in conducting the electrical impulse along the AV conduction system. And generally we are talking about bundle branch blocks. And here you know that if you look at the chest leads, the normal ECG, there is usually S waves in V1 and progressively R wave develops, and you have a R wave in and positive R wave in V5, V6. Here it is opposite, and this pattern we know from our medical school teaching or even early internship teaching that this is a right bundle branch block pattern. Remember that not always do you get this so-called RSR pattern in V1 in right bundle branch block, but this is still a right bundle branch block. So we have the second abnormality, this ECG, which is a right bundle branch block. The T inversions here are part of the right bundle branch block, so they do not really indicate ischemia per se. The next thing to look at is the axis of the ECG. Now, this is something that can be very confusing, particularly if we are going to calculate axis according to Eichhorn triangle and make all kinds of decisions. But again, going back to our basic medical teaching, we have been told, look at L1, look at L2. Right? If there's a positive QRS in L1 and a negative one in L2, and the so-called the QRX are leaving each other, there's a left axis. And if they are opposite direction, they are coming together or they are reaching, there's a right axis. So this patient has a left axis deviation. So essentially, we have identified the abnormalities, which are that patient has a first degree heart block, patient has a right bundle branch block, and patient has a left axis deviation. Now this combination of these in textbooks will tell you it is called a trifascicular block. What is happening here? Now we know that the AV conducting system has a AV node, his bundle, which divides into the right bundle and the left bundle. The left bundle itself divides into a left anterior fascicle, and then it divides into then it goes as a left posterior fascicle. Now, what is happening here is that there is delay in the conduction of the impulse across the AV node. There's a block in the right bundle. There's a block in the left anterior fascicle as denoted by the left axis deviation. So patient is only therefore conducting through the left posterior fascicle. So actually it's not 3 fascicles that are blocked, there are 2 fascicles. So I would prefer to call this a trifascicular conduction defect rather than a trifascicular block. Now you can imagine that in this patient, if this partially blocked AV node gets completely blocked, what will happen? Again, similarly, if the only conducting fascicle, which is the posterior fascicle of the AV conducting system gets blocked, what will happen? Patient will develop complete heart block, which is in fact what the patient developed, and in the ward, patient had this ECG with episode of syncope. So here you can see a clear complete heart block. We see a bradycardia. You can see that the rate is about 40 beats per minute. And you can see that there are lots of P waves without QRS complex. So therefore, there is no longer sinus rhythm, right? And this we know is the pattern that we see in complete heart block. Now, just look at this ECG. It is, I think, important to differentiate sometimes whether a patient is actually having a complete heart block or some degree of second degree heart block, right? If you look at this ECG, you might say that these QRS complexes are actually generated by this P wave. So you can see QRS P here, QRS P here. But if you look very closely, you will see that as it progresses, the PQRS interval becomes shorter and shorter to a point where it nearly overlaps. Now this type of thing is physiologically impossible in a patient who already has some degree of AV block. So this is just coincidentally that the patient has a ventricular rate escape rhythm which is 4 times slower than the atrial rhythm. So it's just coincidence showing us that it might be a second degree heart block. This is important because the prognosis when it comes to heart block is much worse for a person who has complete heart block, who can very easily go into asystole and die, whereas the person with a second degree heart block has some surviving fibers and may not be in such a risk. Look at this ECG strip. You can see that here clearly the PR interval in what appears to be the conducted beat is stable, and this is clearly a high degree of second degree heart block with 3-to-1 conduction. I have yet to see in my career a second degree heart block at 4-to-1 conduction. So basically, if you see something that you think is 4-to-1, that is very unlikely, and most likely is a complete heart block. So this is what I see. Now the important thing is to differentiate between heart block and sinus node disease. And this side we find that when we get referrals from clinicians, not just physicians or registrars, but even cardiologists, 10 out of 8 out of 10 cases, they are mistaken. Right? And that is because the analysis, for some reason, the analysis is not correct. Look at this ECG. What do you see? Again, you have a bradycardia, a range probably at about 40 beats per minute. What is it? What is that you don't see? Yeah, exactly. You don't see P waves. So when you don't see P waves in a bradycardia ECG, it shows that the sinus node is not functioning. Basically, in this patient, sinus node is dead. So the sinus, complete sinus standstill. So compare that to this ECG, where you can see more P waves than QRS complex. This is a very important consideration, because when you see a bradycardia ECG, if you see more P waves than QRS complexes, it's a AV disease, so AV node disease. If you see no P waves or the same number of P waves in a bradycardia ECG, that is a sinus node dysfunction. So what can we learn from this case? That in an elderly patient who presents with syncope and the ECG shows any type of AV block, it may be first degree heart block, it may be a Winkebeck type second degree heart block, just second degree heart block, think that it's a possibility that a syncope is due to an intermittent complete heart block. Very important. In fact, now the literature suggests that a patient, older patient, say in the 80s, who come with unexplained syncope with no other possible cause, it may be worthwhile even putting a pacemaker without any evidence of complete heart block, because that is the most likely cause, and that has been proven on many occasions. A useful rule of thumb is that if you have a bradycardia ECG, if there are more P waves than QRS complexes, is due to some degree of AV block. And if there are QRS complexes are equal in number or more than P waves, is likely due to a sick sinus syndrome. Okay. So the second case is a young man, and I'm saying young because now I think the middle age has been pushed forward to 65, so we all can consider ourselves young, and I think that's quite a good day. So this young man presented to the ETU, again at the NHSL, of palpitations. He was very distressed, and he compared lightheadedness. Right? Now, examination, he was slightly confused, he was disoriented in time, had a low volume pulse, and a very fast heart rate of 180 beats per minute. Blood pressure was low, and he was basically very uncomfortable. So he was admitted to he was treated at the ETU initially. He was given emergency treatment and he stabilized. Going back to his history, he had no significant medical history other than he had a non-STEMI about 6 years ago. So once the ETU doctor saw him, he was able to also get a 12-lead ECG before he gave the treatment. And then thereafter, the patient was transferred to the medical ward, where they had done a lot of investigations. Troponins were negative, and the only abnormality was a slight depression in the LV ejection fraction, which is 50%. Nothing wrong with the wall motions, or no evidence of anything else. And this was the ECG that he presented to in the ETU. So now, going again back to our basic principles, we see that patient has a tachycardia. The RR intervals, they are about a little bit more than 1 square, That's 1.5 squares. That means about 180 is correct, right? And here what we see that we don't see any P waves. So therefore, they may be hidden because of the tachycardia, but we still don't see P waves. So we cannot say this is a sinus rhythm. And if you look at the QRS complexes, they are broad. So here we have a QRS complexes which are more than 100 milliseconds. So they are broad QRS complexes. So here we are having a regular non-sinus rhythm, a broad tachycardia. Right? If you look very closely, you might actually be able to see some P waves appearing here and there. So again, if you look at these P waves, right? And so this basically confirms that it is not a sinus rhythm. These are what we call dissociated P waves. So what is the diagnosis? What you call regular broad complete tachycardia. What is the diagnosis? Is there a differential diagnosis or not? I think for practical purposes, no. This is ventricular tachycardia until proven otherwise. And if you diagnose ventricular tachycardia in a patient with a regular broad complete tachycardia, you will be wrong only 20% of the time. You'll be right 80% of the time, which I think for a medical condition is very, very good. Right? Just to show you this ECG, this is again a broad complete tachycardia, but here you notice that there is some irregularity in the RR intervals over here. Now, if you look at this, we know as medical students we were told if you feel a pulse and it is irregular diagnosis is atrial fibrillation. So here it is atrial fibrillation. So if you see a rhythm, whether it's narrow or broad, with this irregular, think atrial fibrillation. Why? Because treatment of this might be slightly different to a ventricular tachycardia, and I can't go into it because such a complex subject in itself, but you have to make a note of this. Right. So questions. What was the treatment given? How did this ETU doctor treat this patient and stabilize the patient? Anyone? Yes, DC cardioversion. And that is definitely the treatment to be given. So it is a first-line treatment for a patient coming with VT. Why was the DC cardioversion given? Because there was evidence suggests that the patient was hemodynamic unstable, and it's very likely that if this arrhythmia continued, patient may have gone into VF and may have died. So this is a very important lesson to learn, that in a patient coming with a VT and who shows signs of instability, it is important to give urgent DC cardioversion. Right? Okay. The ETU doctor had taken pains to get a 12-lead ECG. Would it have made a difference in the management if he didn't get a 12-lead ECG? No. I mean, if he didn't get a 12-lead ECG, the rhythm strip would have been enough to diagnose a VT and he could have treated the patient. But later on, it's very important for us to see a 12-lead ECG of the rhythm, because one thing is that there are sometimes some ventricular tachycardias which are not so dangerous. There are benign ventricular tachycardias, and these are treated quite differently. Similarly, by seeing the 12-lead ECG, we might be able to determine where the VT is arising from, and that might be helpful. For instance, if you're planning ablation procedure, we would like to know whether it's the right side or left side. We don't want to go to the wrong side in the initial process. So it's useful to get a 12-lead ECG of a ventricular tachycardia if possible. But you should probably not get 12-lead ECGs like this, which is an ECG taken about 2 years ago in a leading teaching hospital ETU. What does it show? This bizarre complexes. Yes, this is ventricular fibrillation. So you don't really want to don't hang around taking 12-lead ECGs of ventricular fibrillation. You need to cardiovert the patient. Luckily, this patient survived. Now, what about the cause of the VT? The only thing we have is the history that the patient had a non-STEMI 6 years ago. LV function was normal, more or less, and there was nothing to show that the patient had any other problem going on. But what happens is that even in patients who have non-STEMIs, there can be small areas of myocardial damage which eventually fibrose. And these fibrose areas, the fibrosis matures to a point where later on they become a substrate for VT. So it's very common to see patients who had an MI or an STEMI some time ago presenting 6 years, 10, 5, 6, 7 years, or even 10 years later with VT with nothing in between. So it's a very important thing. Maybe if we do a CMRI, we might be able to find these 5 fibrotic areas. Then what do we learn from this case? Most important, to diagnose all broad complex tachycardias as VT, you will rarely be wrong. And that DC cardioversion is the first line of treatment for all patients with unstable VT, and it is safe, it is effective. Just keep in mind that an irregular broad complex tachycardia, even a narrow tachycardia, is very likely an AF, and therefore treatment might slightly differ. And if it is possible, please take a 12-lead ECG before treating the patient. Okay, to a final case. This is a young woman who again presented to the ETU, again NHSL, with palpitations. She was otherwise okay. The only thing she had was palpitations. And she was found to have narrow complex tachycardia, again around 180 beats per minute. And the ETU doctor gave a carotid sinus massage, which terminated the tachycardia. And this is what the ECG was that she presented with. Again, you see that if you go by first principle, yes, there's a tachycardia, right? You can't really see any P waves as such. Somebody might say it's just that it's too fast and the P waves are buried in the QRS complex, so you can't say. You can't really say, but you can't see P waves, right? And of course, it is narrow complex because the QRS duration is very, very short. So this is a regular narrow complex tachycardia. Okay. I can tell you now that if you see a narrow complex tachycardia like this, it is always a supraventricular tachycardia. So you don't have to panic because this patient is not going to die on you. You have time to do something. So it's very often we have patients sent from GP practices to the ETUs and OP saying, oh, there's something wrong with the ECG, please run to the hospital. This is very easily managed at even the most basic outpatient department because we can do a carotid sinus massage very safely. What about carotid sinus massage per se? Does all SVTs respond to carotid sinus massage? Now, what happens in a carotid sinus massage is that it increases vagal tone, and this causes transient block in the AV node. That is what happens. And can that terminate all our SVTs? Now, we know that what the supraventricular tachycardias that are terminated by carotid sinus massage are ones that use the AV node as part of its conducting pathway, as part of its circuit. And luckily for us, the two commonest ones, the AV nodal reentrant tachycardia, which is due to duality of the AV node, and atrioventricular reentrant tachycardia, which is generally due to an accessory pathway, usually uses the AV node as one of its pathways or the part of its circuit, and therefore by doing carotid sinus massage, we can actually terminate these tachycardias. Things like atrial tachycardia and atrial flutters generally merely use the AV node to conduct the rhythm rather than as part of its pathway. And luckily for us again, if you take all narrow complex tachycardias, 95% of all narrow complex tachycardias are AVNRT and AVRT. Right? Okay. Right. So you have patient is very happy, patient wants to go home, you have done the ward round, and you have said, okay, get a ECG done and discharge her, and you've gone back to the lounge. Soon after, the HO comes running to you saying, sir, there's a problem. This patient's ECG looks like this, what is happening? And you look at it, you get a bit worried, and you show it to your cardiology colleague who is next to you. Very, very unusual to have a cardiology colleague in the lounge, but anyway, he's there, and you show it to him. He says, oh, this is terrible. Tomorrow I will arrange an angiogram at Langa Hospital. Right? So what are you going to do? Are you going to go along with the cardiologist's suggestion? Are you going to start some anti-anginal tablets because the patient is 36 years, no other symptoms, is fine, and refer back later? Or are you just going to reassure her and repeat the ECG in a couple of weeks? What would you do? Any show of hands? First option? Yes, okay. Second option? 1 or 2 years, yes. But our third option, yeah, few more, right, okay. Well, actually, third option is what we should be doing. Why? Because this is what you call the memory sign, right? This is a very well-known thing. In an arrhythmia, after arrhythmia terminates, especially if the arrhythmia terminates after cardioversion, they get these widespread T inversions, which are seen, which is usually resolved in about a couple of weeks. Right? So what you can do is, in a young patient, you just reassure the patient and you get an ECG done in about a couple of weeks. If it's an older patient, it may be worthwhile taking a history to find out whether the patient has had an angina and whether the patient had past history of ischemic heart disease, and just do a troponin to see whether its troponin is negative. And if these are negative and it has no history of angina, then you can safely discharge the patient, get the patient back in a couple of weeks to your clinic, do the ECG, and that's found to be normal. And what do we learn from this case? That all narrow complex tachycardias can be considered to be SVTs, don't worry about it, right? And the carotid sinus massage is safe and effective in terminating most narrow complex tachycardias. And that diffuse T inversions following termination of a SVT is not due to ischemia, but due to a memory sign. So just to kind of recapitulate on the earlier learning points, that in a bradycardia patient who's coming with syncope, particularly if they're older patients, any evidence of AV disease on the ECG, think the possibility of an intermittent complete heart block. And a useful rule of thumb is that in a brady ECG, more P waves than QRS complexes, AV node disease. If the QRS complexes are equal in number or more than P waves, it is sinus node disease. And if you have a patient with a broad complex tachycardia, it is VT. Don't think otherwise, because it can be rarely be wrong. And the DC cardioversion is the safe, effective, and first-line treatment for patients who are unstable with VT. Just keep in mind that an irregular broad complex tachycardia could be AF, so you might have to think twice about treatment. And if possible, and if it's safe, take a 12-lead ECG before treating. Thank you.
Chris, the clarity of the lecture, there are no questions. Then we will proceed with the awarding of the certificate. May I invite Dr. Priyankara Jayawardena again, Vice President of the Sri Lanka Society of Internal Medicine, to come and hand over the certificate.